A very good afternoon to all of you. At the outset, I express my sincere thanks to Dr. Jaydev and his colleagues for asking me this important session. Today's topic is Thyroid and Comorbidities latest update. Various thyroid disorders are associated with various comorbidities, more common in hypothyroidism. Various studies have shown that hypothyroidism patients have higher incidence of diabetes, hypertension, obesity, bronchial asthma, etc. They also have higher incidence of hypercholesterolemia, there's a depression, mild cognitive impairment leading to dementia, anemia, carpal tunnel syndrome, and recently it has been detected that hypothyroid patient there is an association between non-alcoholic fatty liver disease and hypothyroidism. Similarly, hyperthyroid patients also have comorbidities like supraventricular tachycardia leading to atrial fibrillation, thromboembolic stroke, etc. To highlight these things, we have an eminent speaker, none other than Dr.P. Jabbar. He is Additional Director, Indian Institute of Diabetes, Professor and Head of the Department of Endocrinology, Medical College, Trivandrum. He has presented papers in various national and international forums. Dr. Jabbar.
Good afternoon, everyone. Respected Chair, Ramesan sir, faculties, senior members of the profession, friends, ladies and gentlemen. My topic for today is diabetes and thyroid. So my objective is very, very simple. At the end of this session, the participants should know, is there any cross-link between thyroid and diabetes? What is the prevalence of thyroid disease in diabetes? What are the consequences of hypothyroidism in diabetes mellitus? How to screen for this thyroid disease? That's my plan of action for today. If you look into these patients' data, he is a gentleman working in Chicago, a software engineer. He is having diabetes mellitus for the last 13 years, type 1. After 10 years of diagnosis, he got an abdominal problem. He underwent a surgery. Only at that time, the people were looking into the thyroid status. It was too late, and the thyroid report was very, very suggestive of gross hypothyroidism. So when to look for thyroid dysfunction in a diabetic patient and how to treat, these are the plans of action for me. Now, if you are looking into the prevalence data, see, diabetes and thyroid, the most common endocrine disease, frequently coexist. That's a problem. If you are looking into the literature across the world, the figure quoted as 5% up to 20%. We have a data from India. The reported incidence of thyroid dysfunction is to a tune of 20%. It's very, very important. It's an amazing figure is coming out, right? Okay. But overall, the prevalence rate somewhere around 14%, and the more incidence reported in type 1 female patient. That is another interesting story. Very interestingly, what is happening between the type 2 diabetes mellitus and thyroid, still we do not know. It's not clearly known. But one thing is sure, the incidence of thyroid dysfunction in type 2 diabetes mellitus is also increasing. Most of these patients, female patients, they can go for postpartum thyroiditis also around 20%. Yet another interesting phenomenon here, if the patient has got gut positivity, they are all risk candidate for developing some sort of autoimmune thyroid disease. Positive antibodies in this patient, they can go for clinical or subclinical hypothyroidism in near future or in the future. Now, what is the pathophysiology? That's a very important issue we should address. What is the pathophysiology? Why these type 2 diabetic patients are developing thyroid dysfunction? We do not know. But see, let us look into the data. Data will tell you that you have huge number of patients with type 2 diabetes mellitus. You can see here, 16% with the subclinical hypothyroidism, 23%, around 40% of in these data, they have included only 200 or 220 patients only. Out of these patients, around 40% has got some sort of thyroid dysfunction. Very interesting information, those with the age cutoff of more than 45 and obesity. So these are the high risk candidate for developing diabetes mellitus, thyroid dysfunction in diabetes. Now autoimmunity, if you look into the autoimmune spectrum, that could be a Graves' disease or Hashimoto's thyroiditis or postpartum thyroiditis. It coexists and they can go for polyglandular immune syndromes also. So what I want to tell you that if you have a patient with a type 1 diabetes mellitus, it is mandated to look for dysfunction of other glands. That's a carrier message. Now what are the effects of diabetes mellitus on thyroid hormone? See, diabetes can produce a lot of alteration in the thyroid function. Nocturnal TSH peak is reduced. Reduction of levels of T3 level because of the conversion of T4 to T3 is coming down. Larger thyroid gland, interestingly they can have nodules also in the thyroid gland. High prevalence is documented with Graves' disease. Yet another interesting phenomenon, if the patient has got Graves' disease, if they are developing ophthalmopathy, they can have very worse type of ophthalmopathy and sometimes vision outcome is not good. So let us look into the hypothyroidism first. See, let us read one case. It's a 45-year-old female referred to Trivandrum Medical College for the assessment. Type 2 diabetes mellitus, this is the facial appearance. Physician was attributing, this could be a simple case of diabetes mellitus and hypothyroid nephropathy. And she was having lot of symptoms. Notable symptoms were fatigue and constipation. Glycosylated hemoglobin, he is correct, glycosylated hemoglobin was 7.8%. And with this parameter, we thought we will go for the thyroid function test also with this facial appearance. If you are physicians, I think it's not sometimes very difficult to pick up hypothyroidism in case of nephropathy. I will tell you the reason for that. This was a picture. Patient has got T3 of 123, T4 reported as 5.8 and TSH of 56. That was suggestive of primary hypothyroidism. Sometimes difficulties can come during the treatment of hypothyroidism. Now, how it will affect the diabetes mellitus? Hypothyroidism, see this picture will tell you, you have decreased intestinal absorption, you have decreased hepatic glycogenolysis and gluconeogenesis, and eventually this patient will produce sometimes hypoglycemia or requirement of insulin will come down. Since the blood system is defective, peripheral utilization is also defective. Eventually what will happen here is this patient will go for low requirement of insulin and worsening of dyslipidemia. This is what is happening. So LDL, if the patient has got elevated LDL, the natural tendency is to increase or start statins. Please, before that, just look into the thyroid status. Also, if the thyroid status is absolutely normal, you can go for modification of statin or treatment with the statin. Please, yet another important message, hypothyroidism should not be a cause for hypoglycemia if the patient has got absolutely normal pituitary and adrenal gland. That's a very important message you should remember. Now, yet another interesting information, the risk of nephropathy and other microvascular complications, retinopathy, all these complications worse if the patient has got subclinical or clinical hypothyroidism. Now, recurrent hypoglycemia is not that uncommon, and see sometimes if you are giving thyroxine for subclinical hypothyroidism or hypothyroidism, you can reduce the frequency of hypoglycemic episodes. The consequences of hypothyroidism in diabetic patient, of course, there will be acceleration of cardiovascular morbidity issue. See that hypothyroidism can magnify or worsen the CVD risk, and dyslipidemia partly reversible with the thyroxine, simple thyroxine, very cheap molecule. So it's very important to pick up hypothyroidism in case of diabetes mellitus. Now let us come down little subclinical hypothyroidism and diabetes mellitus. Prevalence documented as 5% up to 10%, and in adolescent age group itself, you can get 6% of the patient with the diabetes thyroid dysfunction. So there is a vicious cycle. You can see subclinical hypothyroidism. They can have diabetes mellitus, hyperlipidemia, the worsening of blood pressure, hemostatic disturbance, and ultimately they will go for cardiovascular morbidity and sometimes mortality. So this is one interesting study. They have included a huge number of patients, more than 55,000. See what is happening here, even in the presence of mild elevation of TSH, these patients are risk candidates for developing cardiovascular disease. Especially, see if the TSH exceeding more than 10 micro international units, risk is very high. So at any cost, you should pick up hypothyroidism little early for a good outcome. This is another information. Those who are having negative TPO, they can remain as euthyroid for a long time. If the patient develops positive antibody, the production of hypothyroidism is a little rapid, so this should be prevented. Now, this is another study. They have included 3 groups: high TSH, which antibodies, high TSH, and euthyroid. See the hazard ratio for developing cardiovascular disease. Those who are having high TSH antibodies, very high risk, and high risk, again risk is there, but it's not to a tune of the patient with the antibodies. Euthyroid, it is not very high. This is about myocardial infarction. Aortic calcification also significantly increased if the patient has got elevated TSH and antibodies. That's a message from this slide. And progression of hypothyroidism. You have subclinical hypothyroidism today, and tomorrow these patients can go for frank hypothyroidism. So, but data are conflicting. See, Gray et al. Showed 5% per annum, but another study shows none of the female patients with the type 2 diabetes mellitus, they did not progress for overt hypothyroidism. This is what is showed here is mild elevation of TSH. In presence of insulin resistance, even in euthyroid patient, they can go for adverse cardiac events. Whereas in the absence of insulin resistance, low risk of dyslipidemia and cardiovascular morbidity. Now, this is another interesting story. You can see the effect of thyroxine treatment or glycosylated hemoglobin. With thyroxine, you can see glycosylated hemoglobin is coming down. Here what is showed here, pre-diabetic, 2 groups are pre-diabetic, here diabetes. With thyroxine, so you can see the reduction of glycosylated hemoglobin. This is yet another study, improvement in insulin sensitivity with thyroxine. See, before treatment, insulin level was high because of insulin resistance and C-peptide was level. After treatment, this will get corrected. That is another important message. This is given in one of the medical archives. Clinical treatment of subclinical hypothyroidism, see, evidence is inconclusive. But it showed if the patient has got brittle diabetes mellitus or severe hypoglycemia, if you are giving thyroxine, sometimes that will reduce hypoglycemic episode. That's a message from this slide. Now, this is the, I think, a very interesting topic nowadays, metformin and thyroid. It's an update. See, metformin that can cross blood-brain barrier, eventually that can produce minimal reduction of TSH. If you see this data, you have lot of data are available. Most of this data showed reduction of TSH. Has it got any cardiovascular morbidity implication and all? Till today, we do not know. But there are certain signals saying that, that can produce problems. Now, coming to the second part of story, that is hyperthyroidism and diabetes mellitus. Again, we'll start with a case. You have a patient's age is around 55 years, he's a diabetic for a long time, he is having weight loss. Any patient with a weight loss, think about lot of causes including infection, drugs, all those things. In addition to that, you should consider a differential diagnosis of hyperthyroidism or thyrotoxicosis. And patient positively giving a history that patient is developing darkening or hyperpigmentation of skin. With this, of course, you can consider adrenal insufficiency also in this patient, but mucosa was relatively spared, which is little uncommon in adrenal insufficiency. So, with this data, T3 of 276, T4 of 16.8 and TSH is suppressed. So, you have a classical case of diabetes mellitus with thyrotoxicosis. This patient is on treatment. Of course, endocrinologists may think that the patient has got adrenal insufficiency also. Currently, the cortisol profile is normal. After maintaining or after achieving euthyroid status, definitely we'll look into the adrenal status again. Now, how it will affect the diabetes status? That can produce acceleration of gluconeogenesis, rapid G absorption, and increasing insulin resistance. Another interesting phenomenon that may unmask latent diabetes mellitus, and if you are treating thyroid status, the euglycemia can be achieved in this type of patients. This is see what is shown here, the pathophysiological or hemostatic mechanisms with the hyperthyroidism. So clinical manifestations, very interestingly, poor glycemic control that can precipitate diabetic ketoacidosis with type 2 diabetes mellitus, low thyroid hormone levels in acute hyperglycemic situation that can produce little confusion in the interpretation of thyroid function test in diabetes. Severe diabetes mellitus may be missed in thyrotoxicosis, and thyroid crisis may be masked by hyperglycemia, and these type of patients, because of the non-specific nature of symptomatology, we can get into trouble, and lot of confusion can occur during the clinical workup of this type of patient. See, thyrotoxicosis, these diabetes, poor diabetes control, weight loss, increased appetite, fatigue, all these are the symptoms of hyperthyroidism, diabetes mellitus. You can't differentiate clinically between these two. Nephropathy, if the patient has got diabetes and nephropathy, hypothyroidism is one of the differential diagnosis. Symptoms are more or less same. So what you have to do is you should suspect the possibility of thyroid dysfunction in a diabetic patient and ask for investigation appropriately, then only will get a positive impact on the health. Now, this is very interesting case. It's an alcoholic patient. So, eye changes are attributing to alcoholism, and the patient was giving history of increased bowel movements and little weight reduction also. Everyone was thinking in terms of uncontrolled diabetes mellitus could be the reason. But when we looked into the leg examination, which showed some sort of nodularity here, this was suggestive of Graves' disease. So coexisting hyperthyroidism is not that uncommon, at least in endocrine practice is very common, I would say. Now hyperthyroidism is associated with a lot of cardiovascular problems, tachycardia, systolic hypertension, atrial fibrillation. One of the common teaching is any elderly patient with atrial fibrillation, think about the possibility of thyroid dysfunction, then treat accordingly. Now cardiac mortality, especially in older elderly individuals, very high, and cardiac arrhythmia with pre-existing heart disease, and this can trigger for myocardial ischemia or other heart disease. Now last part of my talk is thyroid and diabetes cancer. Everybody knows that the diabetic patient has got some tendency for developing cancer, many type of cancer. What is shown here now, you have lot of studies which showed there is definite link between thyroid cancer and diabetes mellitus. There are various mechanisms postulated, hyperinsulinemia, increased TSH, here the vitamin D level is coming down, everything put together, all these diabetic patients, at least theoretically I can tell you that this patient is a risk candidate for developing thyroid cancer. Now, the last part of my talk is how to screen. What are the recommendations we have? What will be the recommendation? What we feel that the thyroid status should be assessed in all patients with diabetes mellitus, especially type 1 diabetes mellitus. That is a take-home message from here. If you see the recommendation by various professional forums, ATA recommendations are there, but they feel that type 2 diabetes mellitus may require more frequent testing. And patient with diabetes mellitus, type 1 diabetes mellitus, again more frequent testing. It's an ambiguous statement. American College of Endocrine, in presence of goiter, definitely you should go for this thing, screening. And if the patient has got antibody positivity or any other autoimmune disease, better to look for thyroid dysfunction. Again, after 5 years, they are changing and they are not giving any specific remarks now. American Diabetic Association for type 1 diabetes mellitus, TSH and antibody at diagnosis. That's a recommendation by American Diabetic Association 2009. At diagnosis of type 1 diabetes mellitus, definitely you should look for TSH and antibodies. That's a recommendation. Now, if you are seeing the recommendation by American Diabetic Association, that is 1 year back, children with type 2 diabetes mellitus screen for thyroid ATPO and thyroid globulin antibodies soon after diagnosis, and TSH concentration should be measured when you get a good metabolic control. If absolutely normal, you can reduce the frequency of testing, and if the patient develops symptoms of thyroid dysfunction, thyromegaly, and abnormal growth in type 1 diabetes mellitus, look for hypothyroid status and treat appropriately. The algorithm which showed if the patient is euthyroid and TSH is more than 2 or TPS positive, annual TSH measurement is indicated, and if TSH is less than 2 and ATPO, you can reduce the frequency of testing. Remember my first patient, young patient with type 1 diabetes mellitus, developed hypothyroidism and did not pick up hypothyroidism. And what I feel with these recommendations, we should implement that all patients with type 1 diabetes mellitus as well as type 2 diabetes mellitus should go for thyroid function testing. That's a career message from me. Thank you very much for the kind attention.
Because of the lack of time, one question is allowed.
That cortisol level should be checked after correction of thyrotoxicosis.
See, the cortisol for this patient, you are talking about our patient, no? So cortisol is 18, something like that. Any value more than 18 micrograms, that's taken as normal. But this patient was in a stressful event. So after achieving euthyroid status, we should look into the cortisol profile again. If needed, we'll go for synactin test or ACT stimulation test. That's the usual protocol. For any endocrine investigation, you should maintain U status. That is important before going for any investigation. We have seen lot of investigation. Growth hormone assay, IGF-1. In a setting of hypothyroidism, you won't get any information. Always try to maintain U metabolic state, then ask for investigation. That's a message.
But if the patient is genuinely needing cortisol, no, can we wait for correction of hypothyroidism? If that is also actually deficient.
For this patient, or you are talking about first patient?
No, in general, I am saying.
Can you ask the question again, sir?
No, can you, supposing it is genuinely low cortisol in the patient, barring the stressful situation.
Yeah.
So then would you wait to correct the thyroid?
No, sir.
No.
We don't want to wait for a long time, because if the cortisol level is low, definitely we'll treat. Dr. Matthew, in your opinion? We'll treat. We should not wait.